I'm very happy to be here to speak with you this evening, and thank you very much for that nice introduction.
You earned it.
Oh, well, this year I actually am celebrating 35 years in nursing, and I never thought I'd be saying that. It's like, oh my gosh, 35 years. But not that I thought I would be anywhere else. And I'm really excited to say that. It does give you a different perspective, absolutely from a higher level, I'd say, looking at things at a different level. And also never thought I'd see history repeating itself, which we'll talk a little bit about tonight. I owe a lot to Villanova. I did have to say this. When I went for my master's degree, it was in '97 when I graduated, I had some experience, obviously. Had come to a point where I had to decide what I wanted to do when I grew up, and had to think about what I really liked. And I really liked clinical nursing. I also liked business. And the case management track had a little bit of both. And it was very unique, I think ahead of its time. And it prepared me not to be a case manager, as you see. I was really somebody who had the opportunity to forge some managed care initiatives. So, and I know that there's some others that have had this degree and have done the same. So I hope that those concepts still exist, and maybe there'll be some additional interest in those types of educational endeavors in the future. I had a year to think about this topic. Lynn told me a year ago. And, thinking probably, hey, she's going to be prepared, right? But mostly what I did is I pondered a lot about accountable care. I've had some personal experiences and professional experiences, and I've been thinking at it on an accountable level and with that lens. So a lot of what I'm going to talk about, too, is about my experience this year. Personally, my mother was diagnosed with cancer. It was very sudden. She fell, they found cancer. She's fortunate because they did identify at stage 4. And she's gone through the continuum. And I've gone along with her and experienced the healthcare system directly from that viewpoint. And to your point, as a consumer, different experience, okay? As a consultant, I've also had the opportunity to really be focused on accountable care and still managed care. So I've been working with providers now who are actually assuming risk for services and really needing some experience and support through that process in accountable care organizations. So hopefully you've heard about that too. So I wanted to make sure you knew that. And before we get started, I'm also a student. I know you come here with some expectations, so I kind of want to make sure I go through my agenda, and if there's a topic or a term that you really, really, really came here to hear, I want to make sure I talk about it. So what I'm going to talk about tonight is accountability, accountable care organizations, talk about the business aspects of healthcare. I'm going to talk about consumerism, and I'm going to talk about the implications to our profession. Anything else, any buzzword you wanted to really hear about, that you were burning to hear about, I'd like to hear. Just shoot them out. No terms?
Medical home.
Medical home, okay, I'll talk about that. Anything else? Does it sound like as if I'm going to cover it?
Well, they will have a chance at the end to ask you questions.
All right, okay. The other thing I was hoping that maybe you think about is what accountability and accountable care mean to you before I get started. Kind of think about that, and then as I go along, see if I change your mind a little bit too. All right. So I talked about the goals and our objectives. The agenda is pretty much what I had outlined for you. I'm going to try to focus a lot on the business aspects because I figured that's something that maybe you don't hear a whole lot about in the clinical realm. Accountability. So what is it really? And accountability is pretty widespread in our society today. We hear about it all the time. In the education system, that's in the news right now, right? The Common Core. People don't like it, some people love it. One thing everybody probably would agree is that it is making some changes, and maybe valuable changes. It may not be perfect, but it definitely has spurred change. Business, P&L, right? Profit and loss. You live and die for profit and loss in business.
People will say, yeah, they're really results oriented, but if they're not making money at the end of the day, they don't survive, unless it's a hobby. You know, everybody sees those hobby shops. I want one. I want to have a business where it's just a hobby, but for the most part, you know, it's profit and loss. We know about it. We're more acutely aware of business because of the fact that we've gone through a pretty severe recession. Most people's eyes have been woken up. We felt what happened when business was affected. And they need to be accountable to that profit and loss. Shareholders, we know that. People that are investing in these businesses. And it affects us when even if you don't have an investment, obviously. Personally, I was watching the Today Show. Remember I told you I've been watching with my accountability viewpoint. Have any of you seen this on TV? Where parents actually had their kids, they were pre-teens, and they had a scorecard. They didn't call it a report card, it was a scorecard. And they had criteria, and the kids actually evaluated their parents as parents. And one of the criteria was, do you believe that your parents love you? I think 100% of those kids said yes. But the one thing that a lot of them didn't do well on was whether or not they felt that they understood their moods, which I thought that was interesting. What it did is it spurred conversation, and it did hold them accountable. It took some courage to do that. In business, have you heard of a term called the 360? Good. I mean, bottom line is, businesses recognize, particularly middle managers, how important they are to the function and success of their businesses. A 360 is when you have a 360 view of your performance. Again, it takes a lot of courage. You get a tremendous amount of feedback, and it holds you accountable. If you know your boss, okay, they're going to evaluate you, but your folks that are your peers, the folks that you actually supervise, they get the chance to evaluate you. The feedback's on strengths and weaknesses. You know that's going to be coming up every year. You're going to change behavior, okay, if you're managing to the metrics. There's a video that I didn't link us to, but you know, I figured that it's about a few minutes long, but I think it'd be something that'd be interesting for you to look. It's already on YouTube, of course. Personally, not mentioning YouTube, but we're also in more of an accountable area as children. When I grew up, if I was going to do something that wouldn't necessarily be appropriate, which I'm not saying I did, okay? Nobody was taking pictures of me and posting them on Facebook, right? And my kids were going through high school. Some girl, she was posted a picture with a bottle of alcohol before the prom, pictures taken. She was actually punished and suspended for 2 weeks from school based on that picture. And it was done off campus. So, and 3 strikes you're out. That wasn't the way people were disciplined when I was a kid. So I think that you live in a more accountable, and we live in a more accountable society. The high cost of health care, with the poor results that we've had, how many times did we hear about this with the US healthcare system? Every lecture starts off with this. It gets to a point where, I mean, I'm old, I'm dating myself, but I feel like Billy Joel's playing in my head, like we didn't start the fire, you know? But bottom line is, it's abominable, okay? We have a US healthcare system that costs the most, and we have some poor results. What we don't hear a lot about is that we are #1 in acute care services, though. People still come to us from Canada to the United States, okay? Why? For our tremendous cancer care and some of our acute care services. So it's not all abominable. The primary care story is the one that you have to kind of think about. In fact, we have some real problems with infant mortality, et cetera. The healthcare dollar only stretches so far, though. So as we start to swing dollars into primary care, it's going to be at an expense. We're not going to be having it totally swinging in both ways, right? So you press on the balloon one way, you're going to be seeing some impact with the other. So the jury's still out on what's going to happen to our acute care services as we start to have influx of dollars into primary care. So accountability, what is it? To whom? To what? How? How do you do accountable care? And the definition of accountable care is pretty consistent And it's a concept for organizing and delivering healthcare, striving for better care, and aligning incentives and outcomes. We increase proactive preventative care services. We get access to the right care, to the right person, at the right time, with all the rights, at a lower cost. Bottom line, value-based, data-driven, patient-centered, rewarding quality and quantity, not so much, and reducing costs. There's so many buzzwords in that, it's amazing, isn't it? Value-based, data-driven, patient-centered, all new terms. Not new concepts. But that's pretty much where we're focused at this point. We want accountability because we've been spending a lot of money and we haven't necessarily seen results. We want results. And as money is being spent by us as consumers with high cost deductible plans, we want even more accountability than we have wanted in the past. It's a lot goes with the finance. But there are some factors that really affect accountability. Literacy levels, for example. Most people don't understand healthcare. Our healthcare literacy levels are very low, even with people who have degrees in nursing. Me, for one, my mother was diagnosed with cancer. I did not know anything about her physician. I didn't have anything but soft data. Didn't have any hard data. I had to ask questions. I was like, okay, where do I get information? You go on the web and they have a couple stars against their name. Soft data was easy to get. What do you think of this person? What's their reputation? Would you go to them? But I didn't have the hard data I needed to be able to make that decision for her. So literacy levels, if you don't even know the quality of the providers that you're going to be going to, you don't know much about the quality of care that's being provided. And then in healthcare, many times you're going for services and you don't even know what you're purchasing, right? Because you go in and you don't even know what your diagnosis is going to be. Plus, you don't even know what you're going to purchase. Because the practitioner actually decides for you what you need. And you don't know how that practitioner is even being incentivized. So there's huge, huge responsibility and accountability associated with being a professional in the healthcare business. People rely on us more than in any other walk, I think, in business and life. Alignment is also a critical factor. What do I mean by alignment when it comes to incentives? Is what I'm talking about. So financially, you have the hospital, say, for instance, as a provider of health care, and their goal is to make money. It's a business now. And so if they're not aligned, if the hospital's goals and objectives are not aligned with the outpatient physicians and the accountable care organizations' incentives, that's trying to keep you out of the hospital with better care, lower cost, what's going to happen? Especially if the provider, the physician office, is owned by the hospital. In an accountable care organization, typically you'll have a hospital as part of it. So the misalignment of incentives could be a real problem. Where does it come into play? Well, when it comes time for that organization to make decisions about what resources they're going to be giving to the accountable care organization that they're developing to improve the overall quality of care in the primary care setting, are they going to go there? Or are they going to be going to the new EHR that's being implemented in the acute care service area? These decisions are made from a business perspective. Measurement and analytics lags behind. We do not, repeat, we do not have the right measurement tools, nor do we have appropriate analytics available. We haven't for a while to be able to do this kind of work that I'm going to talk about. to have the right measures, to be able to see where you are and determine the outcomes. All that takes a lot of effort. We don't collect the right data. We don't collect consistent points. We don't have good tools. And many of the players in this space, there are so many, they proliferated. There are a lot of small players now trying to get in there, but it's still really questioning whether or not we have what it takes in healthcare to be able to do this work. So now we're starting to look at other parts of business or other sectors and say, do you have better analytics? Can we borrow from you as a game changer? Think of one area where we have really great analytics, we have great predictive capabilities, and that's in defense. We've invested a lot there, haven't we? Lockheed Martin, for example, what do? They're in charge of Homeland Security databases. All the data from the FBI, Homeland Security, CIA, everywhere, goes into a central depository at Lockheed, and they sort through that, and they determine whether or not they're going to call the president, right? That's real power. They're starting to look at how they can take all that disparate data, that big data, start to look at how things kind of relate and how they can help the healthcare system. Improvement and dissemination, again, that's important to know as well, because if we have found a way to do things better, how can we disseminate that information? How can we get people to really be able to replicate it? We also have issues there. Accountability in healthcare has been evolving. I think that's one thing I want to impress upon you. Whenever you see a big change, and the reason why we're hearing a lot is because the government's been involved. That's why it's really kind of popped. You start to get a little scared and think, oh my gosh, what the heck, am I going to be able to handle this change, and what can I do to be involved? I'm not prepared. But this has truly been an evolution. Professions have always had a moral compass. Either personally, your own moral compass, or you have the Hippocratic Oath. And being a nursing student, just being selected to be a nurse is one process. Going through the education, you're constantly being tested. Are you responsible enough? Are you smart enough? Are you going to be a good person? Because everyone knows this is a profession with gravitas, right? So there's always been some moral guideposts. Managed care, when that came about, we started to think, wait a minute, it's not only just doing good here, there's some potential here for making money. Are the finances actually clouding things? A lot of regulation occurred. And I pulled this particular citation because Ezekiel Emanuel was one of the authors of the Accountable Care Act. And he was thinking about these terms and published an article about accountability during that time. And felt his professional accountability was only one aspect, one domain. But also he had accountability financially, because he was part of an accountable care organization then. And also he had political and government accountability, because they were starting to have regulations around this. You couldn't just have a free-for-all. So it's been evolving, and managed care really had us starting to think a little differently. Healthcare as a business is a concept I really think we need to kind of spend some time on. When systems fail, a lot of times we turn to business. We do this a lot, okay? Think about just even the president, and when we start to look at presidents, we usually have somebody from the business sector in there too, saying they could do it better and manage effectively because they've managed businesses very, very well. And that's not surprising. The other thing is we see it in healthcare a lot as well. Again, I'm going to repeat myself on this because it's so important to remember. If you don't remember anything from what I say tonight, please remember this. Business is about P&L, the bottom line. Okay? And I'm not sure, that's the debate, whether or not all the things that go along with business is always good for patient care. Okay? So the way care is being reimbursed, still is being reimbursed today as well, is a focus on profit. It really is. Nonprofit hospitals, I live in a community where the nonprofit is extremely profitable. I had over 8 of their executives making over $300,000, some into the millions, and also quite profitable, primarily because the business model that they're working within is a monopoly. That's a great business model, by the way. It's a great, it works, okay? But not always great for patient care. Mergers and acquisitions, we're seeing tons of that right now, okay? And we have very little research on the effect on patient care. My community is going to be merging potentially with Penn. Why? And I'll tell you, the article was very good in the paper. They were questioning it. And it's because it's being believed that you have to have at least $10 to $15 billion of revenue to be able to survive in the future. So you have to be bigger to be able to survive. Does everybody know fee-for-service, that concept? In other words, you get paid for services rendered. And how do you make a profit in fee-for-service? More services, right? Okay. Is that great for patient care? Probably not, because there's always going to be those individuals who might be doing services that you don't need, right? So it increases utilization. What percent of care in the United States is considered to be inappropriate? Does anybody want to venture a guess at that? Just shoot it out.
20.
20? Higher.
30 and 40.
What was that?
30 and 40.
30 to 40, that's correct. And I think it's Deb, right?
No.
You did put it up?
I'm Deb.
Oh, okay. I was going to say, somebody from managed care knew that, right?
Yes. You got
They
it.
managed that. I thought. Okay. 30 to 40%. Can you believe 30 to 40% of care is not necessary or appropriate? Well, this is why. Fee for service, okay? Fee for service. Some will argue that it's liability, but most of the time it's because of the fact that you get paid for the services rendered. Global payment, we have global payment, and that's really promoted in accountable care. Global payment is like, so for example, for an episode of care. Have you heard that term, episode of care? Everybody hear that? Pretty much, like, say, take an episode, an easy one is like when you have, well, it's not that easy to go through, but to have a child. It's pretty finite, right? You get pregnant, you have this growth period, and then you have the baby. Right? You're not pregnant forever. So global payment, you know, for one episode. Everything that happens to that person during that time, you get one single payment. That's what global payment is. And it's also being used in bundled payments, where you bundle all the episodes together for a single course of treatment. So it works fairly well in surgeries, like so if you have a knee or hip, have a heart surgery, etc. And there are experiments right now with CMS, Medicare, that they're trying to determine what the effectiveness of bundled payments is. Again, what happens in global payment in a profit mentality is that you may cut some necessary services to make a profit, right? So you got to be careful that you don't just look at the reimbursement model. You have to have some quality measures and some stops and gap measures in there to make sure that quality is still there. And I talked about mergers and acquisitions. So my story, I guess, or my thought process, and where my kind of hopefully can jump off the soapbox, is just be careful about the business practices in healthcare. Not all of them really work really well, and we don't know the implications. Why do we link outcome measures to payment? In a word, it's accountability. In other words, we can mess with the reimbursement model, but we have to really consider what the implications are, always having in the back of our mind that we need to make sure that we can ensure quality. So it's a balancing act. So efforts of health plans and providers to improve accountability really were, again, part of the evolution. They've been doing that, health plans, for some time because they recognized that they had high cost, low quality services, and they wanted to make sure that they could improve the care that's being delivered. Primarily from a business perspective because they wanted to provide value to the companies, the employers, who were getting insurance from them. They were complaining. We know that there are groups that will really come together and said, hey, look, we want to see better quality. Big companies like, you know, the GM of the world, those that have a tremendous amount of money going through systems, have a lot of power. And they came together to establish, hey, we want to see better quality, we want to see lower costs. And so insurers actually work to help with that process as well. And there have been a lot of work here, and there's a lot of organizations, and these are accountable care organizations, who have demonstrated accountability and improvements in healthcare. Group Health Cooperative, Puget Sound is one. Kaiser, huge. Geisinger, it's local to us, Pennsylvania, which I'll talk a little bit about. Intermountain Advocate. Group Health, they were established in 1947, and they came together as a community and said, we want to do better care for the community. And they established governance that included the members of the community, people that belonged to their health plan. And they've really been working on holding themselves accountable, trying to make sure that they were getting feedback from their membership. They have people in the community, beneficiaries on their board, making sure that they're making improvements to the overall quality of life in their communities. So they're an excellent example. They're a nonprofit as well. Kaiser, hopefully you've heard of Kaiser. They're based in California. They're in Arizona. They're pretty much pretty widespread at this point. But their claim to accountability and how they hold their practitioners accountable to care has been largely due because they're a closed system. And it's very well established that closed systems are very, very good at accountable care. Do you know what I mean when I say like a closed system versus an open network system? It means that the doctors, for the most part, the practitioners actually are part of the organization, are owned by them. So Kaiser has physicians who practice and they own those practices, and they also have hospitals, they have health plans, but it's a closed system. And so they were able to control a lot with that closed system. And their claim to fame is really their EHR. They have a large EHR, they have one that's homegrown, and I had the pleasure of working with the person that was in charge of that EHR, and very proud of it. They can collect a lot of data. Remember I told you we don't have a lot of data being collected, but they can collect a lot of data, they can watch, they can see trends, they can identify practitioners and their practice styles, their ordering patterns, etc. But they can also push evidence-based guidelines, like say for instance they have an order form where they could actually select what they should be doing. They could guide that through their EHR. So they have been able to see a lot of improvements in care through their system. And they're really a model. So we've had a lot of private sector examples. The other ones, Geisinger was promoted through the ACA. President Obama cited them specifically. There's a physician, Dr. Steele, who's very involved with them as well. Very innovative, very focused on quality. They have a health plan. They have a closed and open system. But they're located in Danville, rural Pennsylvania. So it's up there. But very innovative in their approaches, very focused on quality, and they have a proven care system that they're selling at this point that they've taken out and they're working with in their innovative approaches. Intermountain is in Utah, again, open system. They have attempted to try to, get care coordinated through their protocols. And Advocate, another system that's open, doing some very good things. So These are all examples. They've been in place for some time. They're not new. Enters the government, right? That's when the rubber hits the road. That's the biggest payer, right? That's the main reason why it's really important when the government gets involved. Medicare, Medicaid system is the #1 payer in our healthcare system today. And what happens is, even though we had those other examples, we didn't necessarily have a call to action until the government got involved. Because when the government takes the reins, then others can follow. Pretty much, the government attacked insurance companies, didn't they? Like Big Bad Insurance. But they knew they couldn't necessarily target who they really wanted to go after. And who they really wanted to go after were the providers. But they knew that through attacking the insurance company, that the insurance company would have to go to the provider. Because unfortunately, the provider is going to get it either which way because of the fact that they're reimbursed in those manner. So the government getting involved is, I think, really important. It was a game changer. But I wanted to make sure that you know that it was an evolution. Not that it was just all of a sudden happened. The belief, I have as belief, because it's actually almost a hope, that ACOs will be able to achieve both quality and cost improvements. That through collaborative delivery of care and services, we'll be able to actually move away from a system that just pays for volume and actually move toward payment for value. However, in almost every piece of literature that you can come up, what the bottom line says is in shared savings between 2010 and 2019, it's expected that we will save $5 billion. So again, don't mistake what the goal is ultimately, because there are so many lectures that start off with the fact that the Medicare system was going to crash. We wouldn't be able to support it, that it was going to impact our overall well-being because of the fact it's going to impact our economy, bottom line. So we knew we had to do something. And the Patient Protection Affordable Act is really trying to focus on the triple aim. Hopefully that's something that you're really familiar with. And that's improving the experience for care of individuals, improving health of the population, and lowering the per capita cost. Problem is we still have problems measuring all these, right? But that's the goal. Questions? What's an ACO? Really, it's a set of healthcare providers, including primary care physicians, specialists, hospitals, all working together, and they accept collaborative accountability for cost and quality of care delivered to a population of patients. This is huge. It's such a different way of looking at things. Remember I told you, incentives still aren't necessarily aligned, so having all those entities even working together is huge. So in an ACO, you don't have to always have own practices too. So, aligning those organizations is one task. Looking at populations is another. And trying to look at the population being here, Medicare patients. So what happens is the federal government will give a group of Medicare patients and say to the ACO, because they have to apply, they say they want to be involved with this. And they say, we want to see you improve care in 33 domains, 33 measures, and we also want to see you improve that bottom line. And we want to see you do it within 3 years. Okay? So you apply, you say, of course I can do that. No data, because the data that you have from the Medicare claims comes to you usually late. Okay? They usually don't have it for a good 6 months to 9 months. It's just a reality. And you've not worked together in the past. Now, established pioneer ACOs, that's not the case. They usually have had some experience with care management and have worked together, but for the most part, they haven't. So you have to build an infrastructure that no longer, it doesn't exist yet, and you also have to be in a situation where you can actually measure that you're making a difference and track and trend within a 3-year period. The requirements I have listed here, hopefully you'll be able to get like a handout, because I thought it would be important for you to have this. But you have a legal structure. You have to have at least 5,000 beneficiaries. You have to provide information on demand to CMS about how you're doing. And you have to have a governing body. And you have to be patient-centered. And you have to have a governing body that has beneficiaries as part of it as well. The other part of it that's integral is that you also have payment for the process. You have 33 measures, and pretty much what happens if you're a small ACO, go all the way down to the last line here. Say, for instance, you're a small ACO, you're not affiliated with a hospital. What they'll do is they'll give you upfront $250,000, plus you'll get $36 per beneficiary, plus you'll get $8 per beneficiary to help develop the infrastructure per month, okay? Think about primary care practices that have not necessarily been getting paid very effectively. They may sign up for a cash flow influx, and then also be in a position where they might take this money but may not necessarily get to those changes very quickly. That happens. So that's why in the 3 years they have to kind of get to a point where they're demonstrating those outcomes before they get even more. But a lot of times in managed care, insurance companies would just give the investment because they recognize that they were reimbursing primary care at a very low rate for quite some time. After the 3-year period, talk a little bit about how shared savings works. I think I have that here as well. What happens is in the first year, you can elect not to take any risk on the downside. In other words, you could be in this arrangement and be able to share in the savings at a certain percentage. And Medicare will allow you not to have to take a loss. So for example, you can get in there, maybe not make an impact on the bottom line and not experience loss. But your reimbursement may be lower. If you choose to accept upside and downside risk, you get even greater reimbursement. That's how this works. The problem is, in some ways, is that you may already be part of an ACO and you may not even know it as a patient. And that's an issue, I think. Because you should know the incentives that your physician, your hospitals, and health systems are working within. The components that are critical to an ACO, you need leadership. You absolutely have to have a structure and governance. I told you about technology. You have to have technology. You have to have measurement and analytics in place, but unfortunately many times they're not necessarily appropriate. Another integral part, though, is care coordination and improvements to demonstrate that you can improve care coordination across the continuum and at a population level. Sorry. Collaboration is very key in these models. I just thought of that. I was like, I turned my phone up, I'm trying to think of the time. I'm like, do you have a clock here?
Nope. No, it's quarter.
Quarter after. Okay. And you need alignment. This is a direct quote from the Kaiser Permanente website. And it mentions again that these ACOs are being formulated, but again, patients may not even be aware that they're part of them. I find it incredulous that it's actually even being published like this. ACOs and HMOs. A lot of times people think an ACO is actually an HMO, but it really is not. It's very different. Today's ACOs, accountable care organizations, have cost sharing, but they're really truly provider driven and they are partnerships. So I have said to you before, CMS will enter into these, insurance companies will enter into these, but they do not always have a downside risk associated with them. And again, that's because in the past, in HMOs and managed care, it used to be that it was not a shared savings, it was truly a risk arrangement, and there were no risk bands, and providers actually lost money in those processes because they had no idea where they were going to be. Also, ACOs do not require patients to stay within network, which is huge. So that causes problems also with measurement and tracking, but it is truly a requirement that you can go outside the ACO, that network, to receive care. And then the other thing I think is important is also the incentives are truly different, and there are definitely regulations that are unique to HMOs versus ACOs. Here's the information about tracking. Again, the tracking involving the 3 years savings with no risk. Track 2, though, is the one that says that you can have risk, downside, upside, and have additional savings. Questions about accountable care organizations? I'm actually part of one right now, and it's really hard work. Doctors, hospital executives coming together, trying to determine how they're going to take care of populations. They're taking on risk. They have data that suggests that they identify high-risk patients within their populations. They know some of the patients that they see, but they're responsible for patients that they don't see also as part of that process. And so it's hard. You know, you have to be in a position where you can engage patients who don't normally seek care to be involved with managed care and getting preventative services. Because if you don't broaden that and try to get to that population, the costs are eventually going to be high for those individuals when they do seek care. And so it's tough. It's a tough process to figure out. There's no prescription. There's no silver bullet. There's no one doing this the same. There have been demonstration projects, but out of the demonstration projects, there was only one that actually made money and saved money. And that was actually one that was in Pennsylvania, again, Health Quality Partners, which was affiliated with the University of Pennsylvania. They were able to demonstrate a net savings of about $390 per member per month, Medicare population. And how they did it is they focused on not just medical care, there was a nursing model that focused on all those other determinants of health. And they used research, and they focused on having mobility, having social support, all those different things that will actually improve the care of an elderly population. So it's kind of neat. It was a truly strongly controlled study. They had an actual control group. And if you look up on Health Quality Partners, they actually have a website. You'll be able to see some of the literature about that initiative. Johns Hopkins, I just want to mention. The Johns Hopkins system is very unique. Remember I told you I had some personal experiences, and I had a personal experience as a patient myself. And believe me, as a nurse, I don't think I'm unusual. I'm fairly critical when I go through the healthcare system, and I was scared. I had to have lung surgery, and I was like, oh my gosh, I'm always the one at the bedside with my family who's going to be there for me, and petrified. But as soon as I walked in the doors at Hopkins, I knew I was in the presence of something very unique. I went in, and the receptionist was very pleasant, very attentive. And then within a few minutes of having that interaction, I was filling out a survey about her services, Joyce. So I knew exactly who I was evaluating. So I filled it out. And then I went into another section of the hospital to get some lab work. got a survey, and they said, well, how was service? So I'm like, oh my God. Gave the feedback, it was excellent, by the way. Went through, and I was going through, very scared through, when you're going out and being wheeled in to get surgery, and very rarely do people read your chart ahead of time, honestly. That they know your history and all those questions that you answer. But there was a technician, not a nurse, a technician who was there to do my ID, which I was still irritated about because I still, anyway, she was trained to do IVs, and she was going to do me, and I'm a hard stick, believe me. And I tell everybody I'm a hard stick, and so it was in my chart. No lie, she came over to me and she said, you know, Mrs. Fessler, I noticed that you're a nurse and that you're a hard stick. She says, since you're a nurse, have you ever noticed why they miss you? I'm like, oh my God, no one had ever asked me that before, ever. And I didn't think to share, because I said to her, oh my gosh, I know exactly why they missed me. I said, my veins roll. So I said, you know what, I bet if they would just put some tension on that arm when they do that stick, you'd get it. No lie, she got it. Now, it might have been pure luck. But I was so impressed with the fact that she asked me that. And I was also thinking, man, why didn't I think of that? After recovery, I was having some difficulty with pain. The nurse right away attended to me. I was having difficulty breathing. The nurse on the floor knew enough to get me oxygen. I didn't want to do those things on your legs. She said that's too bad. I gave her problems with the breathing thing. She said that too bad. You know, I was like, yeah, I got a really good nurse. And so, like, at the end of that experience, oh, this was best. I had chest tubes, and a medical student came to pull them out. I was like, oh my God. I asked him a lot of questions before he did it, but he did it. And bottom line is, what I found, they had a lot of charts out there about satisfaction. And it was because they were doing that satisfaction that people were held accountable. And I feel that Hopkins, and they are the #1 hospital, I think at least 10 years running, was really cool. So this didn't hop here without thought. But the other thing I wanted you to know is I kind of did some digging because I was like so impressed. And I was like, well, gee, why the heck is this like this at Hopkins? And it was because there was a problem. There was a child that died, 18-month-old girl. And her mother was complaining about the care and nobody was listening. And they did some root cause analysis from that. And there's lots of, it was a suit, tons of things in the paper. But they changed, and they changed in a big way. And they became a model for that. Patient experience really spurred innovation. And Apple is a company in business, again, that does this a lot. Basically, they go to the person and they say, what do you like? What do you want? Samsung is another company that's big with that. They're competing pretty nicely with Apple right now, right? And what they do, they go to the customer and they say, what do you want? How do you want this to be better? Shadowing became a major way in which they understood what the customer's experience was. And walking through, going through the emergency department on a gurney, not walking, on a gurney, and then seeing what that person sees, feeling what that person experiences, is really what they're talking about all throughout the system. And it's driven a lot of improvements in accountability in healthcare. Yet another business model, by the way, but I think one that works. Not all bad. Not that I even think the others are bad, but I think it's interesting to note. There's lots of discussion. With my mother's experience, I felt really accountability is a lot about caring. You could tell when you're in the presence of people who care and when they don't care. Caring is still essential in accountability in healthcare, and I think in nursing in particular, not to lose that. 12-hour shifts was a problem. It functions for us. It doesn't help her. They didn't know her case. Can't tell you how often she had a change in practitioner. Now, I'm a nurse. Remember, I started off my lecture I've been in nursing for 35 years, and I kind of like that nursing model, you know, that you follow the patient through. But it's not happening today. Incentives are not known to people. People are not aware that their doctors and hospitals are getting incentivized. And the detractions that are in CMS for admission are not strong enough to drive care in hospitals. It's only about 2% hit. Like there's 2% admissions and you kind of get a slap on the wrist. It's not strong enough to make major changes. So know that going into it. Big data. Have you heard that term? We're using it a lot right now in healthcare, looking at trends, just compiling tons of information. In New Hampshire right now, they're taking all this information and trying to determine how populations and how they're being affected by care. It's really going to have some major impact into our healthcare system and accountability. And I think there's some ethical concerns we need to be concerned about. And I think that governance is a huge issue. Nurses, doctors in the field, in the front line, need to be part of these discussions because you're the folks, we're the folks that are actually going to be implementing these changes. And if you don't know why it's occurring, if you don't understand what it's about, you're not necessarily going to be able to make sure that it actually occurs. This is such a good time to be a nurse. But for 35 years I've been saying that, honestly. Every time I'm in a lecture about the future of nursing, it's always been bright. It really is bright right now, across the board. We need researchers, we need nurses with doctorates in the field because there's so much, I just said, we don't understand. We have a need for measurement and analytics, and that's a real core part of that educational process. We need consultants. We need quality nurses, nurses who understand how to chart and control. We need people that understand how to manage quality. We need case managers. Oh my gosh, do we need case managers? And you know, case managers typically have about 7 years of experience to be able to do that job fairly well. And they also need to have at least a baccalaureate. We don't have enough. Nurse practitioners can't say enough. I mean, primary care in particular, because we just don't have enough primary care providers. Primary care is the focus. Nursing informatics. Definitely need a need for nursing informatics. Why are nurses so valuable? It's because we are very broad in our education, our experience. We really understand a lot. We'd love to be able to have social workers as case managers in the field, but because they don't have a background in medical care, if you've ever looked at their curriculum, they just don't. They did really get into trouble when they're in case management roles. Part of the team? Yes. Not necessarily leading that team. I like Maya Angelou, her quote here, because I think it's important because we have to take baby steps. You and I could take them today, tomorrow. Just read the chart. When you're out and you're a graduate nurse and you're working on your own, just read the chart. Can't tell you, that's a small step, but a lot of people don't. You could be more accountable just by doing that. Care about the person. My mother was in bed and a nurse left her medicine there. You know, it's like a golden rule, you know, you just never do that. And she said, if you want to take it, you can take it. If you don't want to, that's fine. I said, what medicine is this? I said, how? She doesn't know what that medicine is. How can she make that decision whether she wants it or not? I didn't know what it was. I had to look it up. You know what I'm saying? I'm like, oh my gosh. And it wasn't Colace, you know, it was a pain medication. It wasn't just Colace. But Maya says if you are always trying to be normal, you will never know how amazing you can be. You gotta go against the status quo. You know, it's a real drive to be different. And you can be an amazing practitioner today. We're looking for amazing practitioners. We need people not to go with the status quo. And you can do it. Like I said, when you get out there, don't ever forget to look at what's going on with that patient and ask them questions. Simple things. So that's pretty much what I had prepared for this evening. Patient-centered medical home is a how. It's part of accountable care. And a patient-centered medical home is really just a physician practice using criteria, because they have some standards, and making sure that care is provided for their population. And they look at preventative care, they do reminders, it's not episodic. They may create a structure around that. A lot of times they use medical assistants in their practices to do outreach calls, but primarily patient-centered medical home is adding care coordination and preventative health measures to the mix. Thank you. Any questions? Oh, go ahead, Jeff.
Yeah, so Denise, with the advent of so many more companies offering high deductible health plans, what role do you see the consumer playing in the whole accountability and driving the change in healthcare?
I think with transparency, there's been some drive, because of the fact that certain plans like that you might enter into, not just high deductible, but that requires you to actually select based on the cost, and you start to see the unit cost differences, is starting to drive changes. Hospitals are actually concerned about that. I've seen documentation that, oh my gosh, people see that this is the unit cost. So it is driving, transparency is actually driving change, because the hospitals and health systems are concerned about the knowledge. Whether or not it changes behavior is when you see those discrepancies. So I think what's happening is the hospitals now, it's transparent, so now they're trying to get a little bit more in line with their peers.
So that's kind of another follow-up question that I was thinking about. So as leaders in nursing, how do we try to change the culture to make it a more caring culture? Like I read that book about hospitals, and that was a really cool thing that they did. I mean, a very sad story that led to that drastic change, but just in general, as leaders in various organizations, what kinds of things can the leaders do to create that level of caring and accountability that you're encouraging?
I think it starts with the hiring process. That's going to be my first off. When I interview individuals for positions, the first question I ask them is, how do they believe that they're going to advance their practice in this position? If they're just looking for a job, if they're just looking for security, because I've interviewed people that have come to a company, obviously Capital Blue Cross, and they'd say, I want to retire here, but honestly, I want to make sure that I'm looking for caring people that actually wanted to make a difference. That's the first step. The second is, I think, looking at trying to care for the hiree, and I think that's important. So as a manager, you said, I try to demonstrate or try to hold true to treating that person with respect, trying to instill with them that, I care about them. And then lastly, evaluation of that as a parameter. So as they're doing their job, they get feedback from their patients regarding how they felt they were being cared for. So I think that's pretty much how I've been able to do that, and I think others as well.
Thanks.
How would you, I know that you probably as a manager as well, anything else you would have considered?
I think those are all important points. I mean, it really, this whole topic really resonates for me because of my experience working as a health advocate and just hearing from consumers across the country how dissatisfied they are, with the healthcare system. And yet some healthcare practitioners would actually argue with us when we would try to advocate on behalf of the patient, that the system isn't broken. And clearly, because just in that company, thousands of people were calling from across the country every day to say that it was broken, that they couldn't get what they needed. So it's just a real strong area of interest for me in terms of how consumerism is going to impact us in the future.
I don't know if you know, but what the business that she's talking about is a business was born from healthcare executives in insurance. Basically, it's called Healthcare Advocate, right?
Health Advocate.
Health Advocate, where you call a nurse on the phone and you try to get support for that person if you're having problems with the insurance company, if you're having issues with healthcare.
Anything, yeah, any experience in the healthcare system that you're struggling with?
Businesses pop up because of the fact that there's a gap, by the way, in our
Right.
system, so. Other questions? Yes.
Any comments on home care where I think we do have continuity of care, and I see a lot of.
I think home care, I agree that the home care is a lot of times that's the basis for which a lot of care coordinators, their experience come from, because you have some longevity, so to speak, with some of the patients. I think that home care nurses typically have the realization that just because you say something, it's not necessarily going to be done. And they also are face-to-face with medication reconciliation, because they're the ones that actually pull down, open up the cabinets and go through the medications. There's been some history, unfortunately, I think, with some abuse with certain providers within home care, where they've extended services beyond what was necessary, which has brought, I think, the industry some hardship, and unfortunate hardship, which I think they're still dealing with, unfortunately. But yes, I would agree that the home care is excellent and is underutilized a lot of times now because of the fact people aren't thinking all the time about home care. Very valuable. Did I answer your question? Other questions?
You talked about 2% in a hand slap. I didn't understand.
Oh, okay. Hospitals are penalized if they get readmissions. So if you, what happens if you have a readmission within a certain time frame, the hospital isn't paid. But it's only about 2% cap on that. So it's not enough to stop it. So, you could get discharged early, be readmitted, and it's not necessarily paid for. Mm-hmm.
Denise, in outpatient mental health, there's mandated reporting from CMS, and I believe that there was a 1.5 decrease in payment, and then it keeps ballooning up to 7%. And what's happening is that, nurse practitioners, clinical specs, et cetera, are on the bandwagon for this PRST reporting. And the physicians don't seem to want to do that. They want to drop out of the Medicare reimbursement system. And as practitioners, we say to them, wait a minute, we need to think about this, we need to talk about this, because many of the clients that are seen in the outpatient world are Medicare, Medicaid, combination clients. And when you think about that concept, what's going to happen? How are we going to handle this? My perception is that more nurses are going to take on more practice roles and are going to run more clinics outside of the hospital-based centers. Some thoughts on that?
Well, you're starting to see some interest, though, in behavioral health, particularly as part of the patient-centered medical home, and also in accountable care organizations. So I think there's a rethinking about it, because in a shared savings arrangement where you're responsible for a population, that they're being hit heavily by mental health and behavioral health issues, right? So they are now thinking a little differently about it, and there's a lack of access to the services because people dropped out, particularly in adolescent care and child, services. So actually the pendulum is swinging a little differently toward behavioral health because they're seeing as more valuable those services. Who's going to provide them, I'm not sure. I don't think I'm qualified to state. All I'm seeing as a trend is that there's definitely a lot of discussion around it, because primary care practitioners recognize that this is an area that they're not necessarily competent, and also that takes a lot of their time, and it has high costs associated with it. And there are studies that demonstrate that as well in chronic care. So there's a lot of literature right now about that piece. I know it's become more valuable, but I don't know. Reimbursement is still lagging behind there, but they're starting to become part of the shared savings arrangement. You mentioned about patient-centered medical home. There's a concept called medical neighborhood. So basically, that's a big part of the neighborhood is behavioral health, particularly in Medicaid populations. I didn't mention population health management, but it's so hard because each hospital and health system has its own catchment of populations they serve, and they're so different. Bryn Mawr is a lot different than, say, inner city Philadelphia, right? So population health approaches look so different. They may have much more behavioral health support than what in Philadelphia, and different than it might be somewhere else. Yes.
Can you explain the benefit of a bundled care payment?
Yeah, I mean, there's a lot of waste involved, remember I told you, in care, and the bundled care actually forces practitioners to kind of come together and decide what's best for the ultimate pathway. So in the past, if you didn't necessarily bundle care, you might just do the surgery, throw them over into rehab and SNF, and forget about them. Maybe they get into home health. Now, with the bundle payment, you might think, wait a minute, I'm a surgeon, I did this, I want to make sure the care has been provided appropriately. I might want to keep them a little bit for this process because we're just getting one payment for this piece, and maybe do a little bit of rehab and on their way. So the bundle payment, the alignment there is that the payment is for that episode specifically. The problem is remember, there's no requirement to keep that person in that pathway. So communication with the patient is really essential. And I'm telling you, there's so many people that don't even know that they're part of these processes. You may be part of an ACO today and you may not even know it, right? And what I did glean over and glass over, but it's not just Medicare populations. Remember, this is sweeping the nation. Insurance companies are getting into these relationships and have in the past with many providers. And those incentives are there. I am concerned just because, remember I told you I've been sitting here with a thought toward accountability for a while, for a year. My father-in-law passed away, and he had heart failure, and he was starting to come in and out of the hospital. But only since the penalties were associated, at least this is what I was thinking, did somebody really start to talk to him about quality of life and whether or not he wanted to come in again and again and again. And they really moved to make him a DNR, a non-resuscitated person. And he agreed, and I said, do you know what that means? No. It was explained to him in all the medical jargon. And the doctor was kind of irritated with me, but I really wanted to make sure he knew what he was signing up for. Ultimately, he made the right decision, but I mean, still, I kind of questioned the incentives. I was like, wait a minute, it's because you're not getting paid every time he's getting in here? You know, it had me question. I don't know. The hospitalist was the person that was taking care of him. Of course, he didn't know him. Could go on.
So I just wanted to further with your comment about patients not knowing that they're in ACOs. Oftentimes the leadership managing some of these ACO products, for example, in my position, we had a contract with Aetna to do a pilot ACO, project.
Right.
And I was surprised to learn when I suggested that we could provide a patient education video to the members in the ACO that the patients didn't know they were in an ACO. So we could send this video to them to help them be partners in the care because none of these people knew they were in an ACO, which I was incredibly shocked to learn. So, just this is the reality out there, that these decisions are being made for people and they have no idea.
Yeah, and this is health delivery research, by the way. In academia, you get IRBs for these types of research projects, right?
Yeah.
This is a big experiment.
Yeah.
And some of the ACOs are using research and applying research, others are not. A lot of it's in the guise of innovation, right? Best practices aren't always relied upon because they were old. Don't want to use old practices in new problems. You'll hear that. But in my mind, I think I'm always questioning that piece of it because, people aren't aware because of the literacy issues we have. And like I said, I'm a nurse, and I still have issues with literacy as well.
I think we're going to finish.
Okay.
I would just like to make one comment about your last slide about, advanced practice nurses and all the advanced levels.
Yes?
One of the things a colleague just said to me recently, which really resonated with me, was he said, well, I have 24 staff that are graduating as nurse practitioners or nurse advanced practice in anesthesia. And he said, but you know what? I still have to care for the patients at the bedside.
Right.
He said, we need good nurses at the bedside as well who are well educated.
Yes, I agree.
And the nurses that you encountered who read the chart, who knew the things to do, those were your nurses at the bedside. Not that the others aren't important, so I'm just putting the plug in for my colleague administrators who are saying, we still need nurses who care for patients
It's true.
in the acute care setting or in the home settings.
Yes, it's a brain, there is definitely a brain drain that's occurring, I think, because of that. And it's interesting you say that. The nurse who read the chart was going to Villanova part-time in a master's program for advanced practice.
Aha! Who's going someplace else.
Right, okay, it wasn't going to be at the bedside for very long.
I think my closing thought for Denise would be one of the things that she's shown you is the progress in what has gone on. And I think if I could end it perfectly, I would say stay tuned, because this is something in motion and we will be continuing to learn about it.
Absolutely, we don't have the answers. Thank you for your attention.